One last question, I think, before we summarize this. Is there any role for PI3 kinase inhibitors in this disease?
I think I'm waiting the last chance for this.
The last chance?
Yeah, the selective, what's called alpha selective hope. And if this really positive, okay, is not positive, I think.
But I've already seen clinical data that suggests that it's going to be very positive. So we'll see. I mean, I think that the toxicity, at least in our early phase trials, has been manageable, and the efficacy significant. I mean, really quite significant and durable, even after everolimus.
I'm a burn kid. We had neophobia in Germany. We had to stop that. A lot of toxicity.
But that was with
non-specific, right?
That's with pictillisib. No, buparlisib. Yeah.
So again, I'm a burned kid. I would
I used buparlisib too and had significant toxicity, but alpelisib, I haven't seen it. Tacelisib seems to have a little bit more GI toxicity, but efficacy shown with both drugs in early studies. So where they're both in randomized phase 3 trials, and there are other PI3 kinase inhibitors that are selective coming down the pike, I think we'll see drugs approved for ER-positive breast cancer that target the alpha subunit.
Do we believe the circulating PI3 kinase mutation as a biomarker for this?
You are mentioning the BEL-2 trial.
Yeah.
It was a supergroup analysis, which to some extent saves the trial.
Right, well, it saved it potentially. Yeah, it's not going to save the drug, I don't think, at this point.
Difference.
Right.
And let's wait the alpha selective inhibitor.
So the alpha selective are they using it as selection or as a stratification?
So it's the
post-hoc stratification.
You have to have a certain number of patients who have PI3 kinase mutations, but so you have to have the data in order to randomize because they're stratified. But I think that the future is really going to be looking at these cell-free, DNA in blood because it's something that we can get over time. We know that PI3 kinase mutations change over time and increase in the metastatic setting. So I actually thought that the BEL-2 data, although a minority of patients was intriguing, and if it had been negative, maybe they wouldn't have shown it, I don't know. But it was negative looking at tumor when a lot of it was archival tumor. So I think that blood is the way to go going forward, that looking at these PI3 kinase mutations might help us in the future.
Okay, very cool.
What I have learned from you guys from US, don't do too much data massage. Go back to the go
I don't know that we're so good at that.
Go back. No, not you. I have learned this notion or this sentence. So let's go back to the lab and do some additional work and not too much data massage. Okay?
I would agree. That's a great way to kind of end, I think, on don't do too much data massage. So I think this has been extremely informative. Before we end the discussion, I'd like to get some final thoughts from each of our panelists. Dr. Awada?
I think really we are living an exciting time in clinical research. I think the separation of breast cancer in 3 groups or more receptor positive, HER2 positive, triple negative breast cancer, even when we know the heterogeneity of the disease, help us a lot in descending and advancing in clinical treatment of this patient. So I think this is really, for me, was a major advance, supervising in clinical trial those patients and studying each group apart. And we discussed a lot of really new options for our patient and trying to improve this option. And this is a very exciting time.
Hope?
I think that I agree with everything you said. I think to add on, where we are now is really trying, we have some exciting new drugs. We really can change areas of treatment that we couldn't before. But it's critical for us to know moving forward what the natural history of disease is. I mean, it's shocking really that we don't understand well the natural history of metastatic breast cancer with various treatments, that there aren't international registries like that. I think it's really important for us to know who needs what therapy so that we're not giving everybody everything, but that we're trying to really use, and if we can't look at a biomarker, we should be looking at the phenotype of the cancer or how it responded to what you gave it before and is looking like at the present. And I think that some of the international collaborations which are just starting to really create either patient-derived registries of what goes on with them in metastatic disease, looking at collecting blood and tumor tissue and annotating the cancer, are the ways that we're going to move forward very effectively in the metastatic setting, and we're already doing that in the neoadjuvant setting.
Great. Michael?
To sum up, I mean, I always try to see it from the perspective of our patients. Number one, the HER2 positive disease story is not at its end. We have a new beginning, which is good for the patients. In patients with hormone receptor positive disease, we know that they have a long-lasting risk of recurrence and metastasis, and with the new kids on the block, the CDK4/6 inhibitors for Western story, I mean, we have more options. I mean, you have seen in our controversial discussion where to place this treatment first and second and third. I mean, I think we are old enough to know that 25 years ago, we had much less options than today, and today we have many more options. So for the patient, it's a good story, and I hope that we follow up on this in the next meetings, and I'm happy to be part of this development. Thank you.
And again, thank you all. Yeah, thank you all for your contributions to the discussion. On behalf of our panel, we thank you for joining us, and we hope you found this peer exchange discussion to be useful and informative. Again, thank you all very much, and again, thank you for listening to us.
Thanks, Adam.
Thank you.
Thank you.